In this video, I'll be talking about performing a comprehensive assessment of the respiratory system for pediatrics. The objectives of this video is for level 1 RNs to be competently and skillfully obtain a baseline respiratory assessment, which is composed of 3 key parts: look, listen, and feel. The respiratory exam are going to be the same for intubated and extubated patients. This video also includes a demonstration of respiratory assessment of a 7-month-old baby named Jamie, who is accompanied by his mum, Darlene. Good afternoon, Darlene and Jamie.
Good afternoon.
My name is Dane. I'm one of the nurses here, and this morning we're going to do a respiratory examination for Jamie. Is that okay?
Sure.
To do is just to simply observe Jamie sitting on his mum's knees. And I'm going to start off doing that sitting down at the same level as him, because small babies don't like tall adults looming over them. And I'm also going to start off with a little distance from him as well, so that it gives him some time to get used to me as being the nurse here before I go in and do a more detailed examination on him. First, you want to ask yourself, how does this patient's breathing look? Do they look calm and comfortable? For an extubated baby like Jamie, they're always trying to find a position that they can breathe the easiest. It is always best to leave the patient in their most comfortable position while you're doing your examination. Now, you may also see a patient who is experiencing respiratory distress to exhibit a position called tripoding. In this position, their hands and knees are bent over and their body is bent over as well, hunching, and you may notice that they're drooling quite a bit as well. Now, you may also want to sit on the ground if the child is more comfortable sitting on the ground as well. Then you observe their overall appearance. Do they look drowsy, lethargic, anxious, irritable, restless, or do they look pale? Are they mottled? Do you notice cyanosis? You may notice bluish lips, which is known as circummoral cyanosis. Or you may notice it is in their hands and feet, which can indicate that they are in a hypoxia. If it is an older child or adolescent, we would direct the questions at the baby, because that would give them a form of independence and respect. Now, I would also note that he is not using anything to help him to breathe at the moment, such as oxygen. And does Jamie have any regular inhalers to help him breathe as well?
No, he doesn't.
That's very good. Now, the next thing that you want to look at is the child's respiratory rate, which you can simply count by watching the child breathe. The normal rate for a patient should be as follows. I've got my watch set here and I've counted for a minute, and Jamie's respiratory rate is 25, which is about right for a 7-month-old baby. And the next thing on the list that you want to assess is the child's respiratory effort, and to see if the breathing is regular or irregular. Do you see the patient breathe at a nice steady rate, or in tachypnea, or having pauses in their breathing like that of shiny stones? Now, in a normal pediatric patient, it is normal for them to have some variation in their respiratory pattern. However, if the patient is taking very quick breaths, then stops or slows way down, and the breathing rate picks back up again, this can be a very ominous sign of impending respiratory failure. You'll often see that a child is using extra accessory muscles or ways to get a good solid breathe in. Now, the first symptom that we often see is nasal flaring, where their nostrils actually flare out and in as they take a breath. Now, head bobbing, where the head actually bobs back and forth, is something that we often see during a respiratory distress too. Now, we would also assess for any intercostal and subcostal retraction, and if there's any tracheal tuck as well. A retraction is defined as the skin pulling in from the outer walls in toward the ribs. You want to assess the child from their neck down to their thorax. You also need to classify the retractions in terms of location and severity. You also want to look at how the patient's chest rises and falls as they breathe. You should see that the patient is having equal expansion on both sides of their chest normally, and if you notice one side rising more than the other, this needs further investigation. Now, we also want to look at the timing that it takes a patient to take a breath in and a breath out. And we call this the inspiratory to expiratory ratio. Now, it should take about 2 times as long for a patient to exhale their breath as it did to take it in. Now, any changes to the I to E ratio is considered abnormal. And the next thing that we want to look for is drainage or secretions. Is it from their nose? Is it from their mouth? Now, the drainage should be assessed for color, consistency, and amount. It can be small, moderate, copious, thick and thin, clear and white. Now, clear drainage will often indicate normal secretions. Yellow or green may indicate an infection. We would also want to know what is the characteristics of the cough. Is it wet and productive? Or is it dry and hacking? Is it barking and hoarse sounding? Now, if the cough is producing sputum, it may be important to collect that specimen for pathology as well. Now, I've got Jamie here playing with my name tag. It is important to have a currency to be able to examine the child so that they are cooperating with what you're doing as well. Now it's time to listen. You'll need a stethoscope to auscultate anteriorly and posteriorly. Would it be alright just to slip off his top, please?
Yeah, sure.
Ooh, what is that? What is that?
Okay.
What is that?
With you.
That you want to compare the right side to the left side and make sure you listen to both the upper and lower portions of the lungs as well. Now we talk about doing this, what we describe as the Z pattern. We want to start up in the right upper side and then to the left upper side. Oh, it's okay, baby. It's okay. And then you will want to move down a little bit before moving back to the right, moving down a little bit before moving to the left side. And we want to do this for the posterior side as well. Would it be okay just to face? Yeah, that's perfect.
Here we go.
Good boy, good boy. And we want to do the same Z tracking position like we did before. So we start with the upper, going to the other side, moving down before we move to the other side, and going down, always moving down before you change sides. It's very important to compare the quality and the depth of the breath. And we want to also look for any other noises and not just the aeration. There are a few things that you will be able to listen to. First is stridor, which is when the patient's airways is inflamed or obstructed by a foreign body. Other sounds include coarse sounds, or runny, and crackles or rails. It normally indicate pneumonia and pleural effusion. However, it will guarantee an extra investigations as well. Also hear a wheeze, which is a high-pitched noise. If you hear a wheeze in expiratory portion of the breath, it often indicates an obstruction in the upper portions. However, if you hear the expiratory wheeze, it often indicates an obstruction in the lower portions, commonly known in asthmatics and bronchiolitics. Now, if you don't hear any aeration of air at all, that is incredibly concerning. Do you hear no aeration on one side or both sides? Or is it just the upper side or the lower side? Now, it is also important to note that if you hear the wheeze sounds in your initial exam and then the wheeze disappears for some reason, you have to be sure that the patient has not lost their ability to aerate the air at all. The third and last part that you want to do is feel the patient. Now, when the patient talks, you can actually feel something like tactile thermometers. So if you place your hands on the patient's lungs like this and they start speaking like Jamie just did now, I could actually hear the vibration in their lungs. Now this should be also equal on both sides of the lungs as well. And actually looking at his hands, it's nice and warm and it's a pink, lovely pink color as well. And if I do a capillary refill this way, I could see that it took less than 2 seconds. So that is really good. And it's telling me that he's well perfused. Next, I also want to assess his hydration. So I'm feeling his frontal. And I'm looking at his eyes, which are bright and shiny. I'm also looking at his inside his mouth, which is damp and wet. So that tells me he is very well hydrated. Now the last thing that you want to feel for is crepitus. It is something very specific and will happen if air develops under the subcutaneous tissue of the child's chest wall. You can palpate around and will often feel tiny air bubbles along their chest. Now this is very concerning as this can indicate an air leak somewhere under the patient's skin. Now that is all done, and what a great baby! Good job! Good job! Now in conclusion, to obtain a respiratory system assessment, there are 3 key parts: the inspection, the auscultation using a stethoscope, and the palpation part. And finally, document all of your findings as well. Thank you so much for coming in today, darling. And Jamie?
Nice to meet you. Thank you.